The views and opinions expressed on Coffee and Compatibility are those of the podcast host and do not necessarily reflect the official policy or position of ASHI.
Welcome back, everybody, to Coffee and Compatibility. Today, we are so thrilled to be joined by one of the most innovative leaders in transplantation, Dr. Giuliano Testa. Dr. Testa is the chairman of the Simmons Transplant Institute at Baylor University Medical Center and an internationally recognized transplant surgeon. Throughout his career, he has held pioneering advancements in living donor liver transplantation, intestinal transplantation, and what we're going to talk about today for the most part, uterus transplantation. He's a founding member of both the International Society of Uterus Transplantation and the United States Uterus Transplant Consortium, and has authored hundreds of scientific publications. Dr. Testa, thank you so much for joining us on this podcast today. We know you are so busy, and we are thrilled to have a few minutes of your time. May we call you Giuliano?
Of course, and it's a pleasure to be here. Thank you.
Oh, thank you so much. So I guess my initial curiosity, your career started much more broadly in transplantation. How did this concept of wanting to attack uterus transplantation come to you?
Well, so just for the audience, I'm an abdominal transplant surgeon by trade, and I've always dealt with abdominal transplantation and organ transplant in general. I have a side interest in ethics, clinical ethics, for mainly focused then on transplantation, and I happen to be on a panel with other colleagues, and one of the colleagues was, and that was the first time I ever heard about it, spoke about uterus transplant. And I found that fascinating. I did a little bit of homework, and I thought that that was something that really had everything that I always look for, which is innovation, good for people, ethical implication, social implication. And I join it mainly because, as you know, most surgeons have a very big ego, and clearly, having done a lot of abdominal transplants, I said, why not? Let's try to do the uterus as well. But the true story is that the hospital saw a possibility, gave me the funding to initiate the program, and 10 years later, here we are. And he has revolutionized my way of looking at transplant and my outlook on many things, and it's been a great thing for my profession.
Dr. Testa, can I just ask, on a very basic level, what types of patients can benefit from uterus transplants?
Well, clearly this is geared toward women health. The interesting part is it is a transplant, but it is not. It's a fertility treatment at the end of the day. So it's geared toward women who are born without a uterus, or are born with conditions that make so that the uterus is not functioning. And so when they are in gestational age, they cannot have a pregnancy. And is geared toward women that for any reason or another, being this a benign or a malignant process or an accident, as it happens during childbirth, have lost their uterus, but they're still willing to have children. This is not in competition. I say that up front because this is a very common theme with surrogacy or with adoption. It's just another way of achieving the goal of being mothers.
And I think, you bring up a really good point about, how this is such a different patient population than many of our audience is used to, right? And that this sort of serves a different purpose in transplantation, if you will. I'm curious of not only your sort of experience in sort of starting it right? Like having brought it into fruition, but how is it expanded beyond just your center into other areas?
Uh, but there's been a series of surprises in a certain way. You start something that when we did the first one here at Baylor, it was the number 11 in the world. So it's not like we were coming, who knows, for what experience other people have achieved in the past. And every step of the way has been a surprise. Opening a door has opened another door and then another door. And also the downstream effect, the ripple effect on other fields of transplantation only now starts to be evident to many people. But reality is that, again, everything that was learned in transplant has been used to make this technically feasible. Everything else comes from the experience of obstetric gynecology and infertility medicine to make this happen. Because the funny part is that as transplant surgeon and transplant professionals, we intend organ transplantation as something that, whether you like it or not, whether we accept it or not, as a time attached to it. We always speak in terms of survival, right? The survival of this, the survival of that. But then in reality, then you see what happens with uterus transplant. The survival is a lifetime. The uterus doesn't mean anything. The real goal, the real result, the real positive outcome is the birth of the child. Everything else has no meaning whatsoever. And so the beauty of it for a transplant surgeon, for a transplant professional, is all the sudden that you don't think any longer in 80% survival at 5 years or whatever that is, you think lifetime. And it's a beautiful, if you stop for a second and you think the implications that even the emotional implication for the couples and women who embark in this adventure, I think is phenomenal.
Yeah, I can't imagine. I mean, I think probably maybe Jeremy, certainly myself, maybe Dr. Weimer as well. We have seen, living donor transplant reveals in solid organ transplantation. Those emotions are so strong. I can't imagine the emotions coming from a woman, a couple that have been through that kind of journey. Is it true that a lot of the people that come to you have already tried many other things? If they do have a uterus or there's lack of function, have they tried IVF? Have they tried or thought of surrogacy? And this is, kind of something they're doing after they have tried a lot of other things?
Yeah, the most typical and unfortunately dramatic presentation is the one of the young woman who is now trying to set up a family and finds somebody that is the person she wants to spend her life with, but she cannot have babies. And usually these women find out that that's the reality for them when they are in the 14, 15 years, 16 years of age, when they don't have a period. And all of a sudden somebody discloses to them, well, you don't have the uterus. You may have a very good functioning ovaries, but the house is not there. And it's dramatically revealing for them to know that what we give for granted. Most of us, the default scenario is I find somebody I love, I get together with this person, and then we're going to have a family. That's not the reality for 1 out of 10, by the way, but it's not reality for these women. And so you see really a life-changing event when for the first time they hold this baby. It's a phenomenal watch. And I've seen people changing posture, changing expression in their faces, changing outlook in life because of this. And I understand that. I'm not trying to dramatize this, but truly, you can, in a certain way, dramatize it if you think that our normal life doesn't even take in consideration for the great majority of us that something else is going to happen to our lineage, that we're going to have kids, and all of a sudden you change that. You change the story. The narrative is you are like everybody else. We did several studies looking at the emotional implication of uterus transplant. One of the quotes that I always like, it seems a very really mundane quote, but in my opinion, it is not, is the one of our recipients who says, when I walk into the supermarket and I was pregnant with my baby. I did not have to explain to anybody that that was somebody else. It was a surrogacy, it was adoption or something like that. So it's the return to normalcy, which is phenomenal, which is true for organ transplantation in general, with the caveats that you got the immunosuppression, you got the risk of infection, you got the visits and the laboratory work post-op and all of this. This is as natural as it gets, in few words.
Yeah, thank you for walking us through that. What a special life-changing experience this has to be. I'd like to ask about donors. What makes a good donor for this procedure? And is it limited to only living donors, or is deceased donation possible as well?
Let me address the last part first, whether this is open to deceased and living donation. It's both. And the success is good with both. Then there are logistics and supply and demand, as usual, that dictate in a certain way the way that the field is going. The funny story about this, or the phenomenal story, without using any hyperbole, is that the firstborn in Sweden in 2014, Dr. Johannesson, Lisa Johannesson, who's now practically my partner in crime here at Baylor, was part of the original team in Gothenburg in Sweden, where they had the first success with a living donor. That living donor was 61 years of age when she donated the uterus. So she was already menopausal. And what they did, they stimulate again with hormones a cycle. They proved that that uterus was working. They took it, they implanted it, and guess what? A couple of years later, because they used to wait a year between implant and embryo transfer, a kid is born. So that uterus was 63 years of age when delivered a baby. I think it says a lot about how resilient reproduction is in human beings. But having said that, yes, it's living donor. The other beautiful story is how generous women are in general. You know, there is always this problem with supply and demand for organ transplantation. We literally have a list of women who are willing to donate their uterus to somebody else. And when we investigate and we ask, why you want to do this? You don't need a hysterectomy. The response was probably on everybody, not in the great majority, in everybody, I had a chance to have a child on my own, and I would like to give the same chance to somebody else. So that, in my opinion, says a lot about altruistic behavior and the emotion that stay behind the reproduction and the fertility for us, for all of us.
So does that mean, I'm so sorry, Kelly, does that mean there is a registry for
There is no
these
really,
donors?
no, sorry, no, there is no really a registry, but we didn't know how to advertise the fact that uterus transfer was a thing. And so we did what we thought was the easiest thing to do. Go to the newspaper and say, Baylor is going to start a uterus transplant program. And all of a sudden, we had, in the span of about 2 weeks, hundreds of requests on either side. That was a surprise. Not only of women who wanted to have a uterus transplant, but a woman who said, hey, I don't use mine anymore. My husband and I are done. My husband, for example, had a vasectomy. We don't want to have any kids. So we're willing to donate. And all of a sudden, we have a list of women, according to their blood type, that can be available, if we call them, to donate to a specific donor.
Wow. So I want to get on my lady soapbox here for a minute, because you said some really important things that I think bear repeating. Number one, like the amazing power and resiliency of the female human body. Way to go, ladies. Like, great design. And you have proven it with that first case. And like the amazing caring heart of women for other women. This story is always a little bit about woman power, but wow, you really bring that out. So I want to roll around in that for a minute. Way to go, ladies. But then you also said something in there that is a wonderful segue. You said something about being blood type compatible. So let's get technical. We're HLA people here. So I am super curious. How do you assess the immunologic compatibility between a potential uterus recipient and a potential uterus donor? What are you looking at? You're clearly looking at ABO. Are you also looking at HLA?
So we're looking at ABO as our number one approach, clearly. If we can, we look at HLA and we try to match as much as possible. It's not always possible, clearly, but if there are two donors, same blood type, and then we see that there are less mismatch on one donor than the other, we go for, without, I want to be clear about that, without really knowing the implication of the HLA. Is too early to understand the implication of HLA mismatching in uterus transplantation. And then, of course, we go by cross-match like everybody would do before the transplant to make sure that we don't go in trouble from the get-go. One interesting sequela to this is that very young recipients, no chronic disease, assumption is they have a very powerful immune system. And so the likelihood of having rejection after a transplant supposedly is high. We have had rejection, but reality is that although the incidence of rejection is relatively high, in our program is about 45%, which is higher than what we have in a kidney transplant or in a liver transplant. But despite this, the severity of the rejection is I would say moderate to mild, and we've been able to treat all of this rejection without any issues. So there is also something there about the immunogenicity of the uterus, and there is a lot to learn in terms of immunosuppression and possibly about matching too, because clearly because of the interaction that will occur between the placenta and the newborn, there is something there that cannot just be a simple ABO or HLA matching. It's deeper than that, only that we don't know. And we hope we can shed some lights with this new transplant.
I think the possibilities are fascinating, because so much of what we were able to very early on learn about immune systems and about HLA came from multiparous women.
Yeah.
So you're at like what is historic is new again forefront of this area. All the interplay between the fetal maternal interface and all of those immune components. We don't talk about some of the non-classical HLA systems very much, but HLA-G, for instance, is really important for tolerance at that fetal maternal interface. So I wonder if someday we will start to talk more about HLA-G because of the work that you're doing. But I do want to ask really specifically, you mentioned cross-matching. Are you doing only physical cross-matching in these cases, or are you applying antibody detection and virtual cross-matching to these cases as well?
We have several, if not more than half of our recipients come from outside the United States. So it's easy to do a virtual just to start screening, just having a general screening pattern in the beginning. But then we do, of course, a regular cross match. Just let me add something to what you just said. There are several things that are fascinating about uterus transplant. Number one, it's easy to do a biopsy in the uterus. We don't have a biomarker for rejection, and the only way we can monitor is by doing serial biopsies. The biopsies, as you may imagine, is a cervical biopsy. Aside the discomfort of being on a chair for 3 minutes, there is no pain involved, and there is really no complication involved if it's done properly. So all of a sudden, you have access to serial biopsies in a transplant recipient, which is fairly unique, right? Number two, you would imagine that with a pregnancy, you start to really, I use a very later, mess up the immune system because you had the donor, the recipient, and now you got the child, and you got all the blood that's been exchanged, and all these phenomenal things that happen during pregnancy and live birth. And so you would expect that something else will happen for the second pregnancy because these uteri are kept when the family wants for a second pregnancy or even a third. But we don't see that an increase in immunogenicity or immunoreactivity after the second pregnancy. So that's another interesting point that would probably be interesting to study if we could. The other thing is that once we stop immunosuppression, clearly there's going to be a rebound, right? And as a matter of fact, all of them will develop DSA after stopping immunosuppression. But the important thing will be to know what kind of DSA are you producing, number one. And number two is how long those DSA, what's the memory behind that? Because that will have implication also for people who have a second transplant for a kidney or for a liver or something like that. And it's much easier to study in a model. I used with a lot of careful attention the word model, but on a patient, on a recipient that does not have any clinical noise associated to her. Those are healthy patients. They have no chronic disease. They have no decrease in immunoreactivity because of, for example, chronic kidney failure. So they have a healthy immune system. And then you can study really the genotype from the get-go of donor, recipient, child, second child, and then what happens afterwards. So there is a lot behind this, and I hope that we will be able to study these things. They will benefit everybody, and not only transplant, and that's the important thing. They will benefit also the world of fertility and pregnancy, trying to understand some of the immunological causes behind miscarriages, serious miscarriages, or things of this nature.
Wow. We've got a huge fan here. I'm going to be waiting with bated breath for every single publication. This is fascinating. I have one more question, and then I promise my co-hosts they can wrestle it away from me, because we do see throughout the pregnancy the antibodies increase, and there's even a thought that those antibodies play a role in helping to initiate the natural process of the child being evicted the way that they should be, right? So I'm interested to see what you find. Do you have women that experience preeclampsia?
Yeah.
So tell us just briefly about that. Like, how often does that happen? Like, is it kind of an average occurrence?
So preeclampsia is an occurrence that is well known in the women who have received a transplant of a different nature, liver, kidney. They have an increased incidence of preeclampsia or eclampsia in comparison with regular people with no transplant. And that's probably an effect either of the chronic underlying disease or of the immune suppression. So we were expecting a high rate of preeclampsia. Reality is that we have about 10%, 11% is not high, but we really monitor very closely for it. We did not have to date a very severe episode of preeclampsia evolving into true eclampsia. There was one in Sweden in the first series. So we're very careful about that. But it is something that you need to monitor for. But the other important thing you just mentioned is true. There is a change in the immunoreactivity immune system during pregnancy, but also the pregnant women are less immunoreactive. So you can really drop your immunosuppression during pregnancy without having any really severe effect on the uterus or incidence of rejection. All those things, these fluctuations are very interesting from a scientific point of view.
So I have another basic question. You'll forgive me, but I was trying to research this, and I read something interesting that it seems like you remove the uterus after childbearing is finished. Is that true? And if so, you referenced earlier taking patients off immunosuppression. What does immunosuppression look like after the uterus is removed?
So the question is whether we remove the uterus. Yes, there is we give let's say a maximum of 5 years to the time that the uterus is with the recipient. The only reason why this time limit is there is because we do not want to expose healthy recipients to prolonged immunosuppression, knowing that the side effects may be important. That's another big question about uterus transplant. What is the long-term effect for a woman in her 20 who has received immunosuppression for 2, 3, 4, 5 years? What is going to be the long-term effect when she's 70? We don't know this. So we're trying to keep up with this information. Yes, we do take the uterus out after either pregnancy has been achieved or 5 years have elapsed. And then we stop immunosuppression. And at that point, as I said, usually we see a decrease in GFR, so glomerular filtration rate, proxy for kidney function, during the time the immunosuppression is given. And then we see a rebound of the GFR after we take away the immunosuppression is based on calcineurin inhibitors, so CNIs. And of course, they have a vasoconstrictive effect on the kidney vasculature, and that may explain the drop in GFR and may explain why it goes back to normal after you stop those medications. Now, that's one. But then what the other effect on the immune system, immunosuppression given, and the fact that we give also thymoglobulin as an induction therapy on a healthy human being, will we see an increase in some immunologic problems at the age of 60, 70? I really don't have that answer. Because think about, this is a population that's we do have pediatric recipients for organ transplant, and we can follow them for 40 years, 50 years. And we know some of them we lose their graft on a chronic rejection pathway that we don't really understand yet, whether it's humoral related or T-cell mediated. That's a study on its own, clearly. The tolerance network in the United States has been accumulating the data about this. But then this is a completely different population, right? This is not a recipient of an organ that stays there. This is a recipient of an organ that is gone, but definitely has somewhat influenced the immune system of that person. And this is the long-term effect of medications 60 years later that we don't know about. So questions are there.
Yeah, and I mean, I think to end, something that's very interesting is, there's a lot of science that you mentioned going on behind the scenes and still to be done to further understand the immunology and sort of all the many aspects that go on for these sorts of transplantations. And I think we're all going to be anxiously awaiting to see what those studies come, because I think there's an excellent opportunity for us to learn across transplantation. But the last question to you, sir, is, you've started this wonderful program and you touched on some of the emotional impacts it has on the recipients and their families. And I'm curious, how many do your center perform, or how do you see this growing as you continue to grow your program?
So I hope this will grow to become a standard fertility treatment for any woman who has that kind of problem. It's called absolute uterine infertility. So fertility issues tied up to the absence of the uterus. We have done 44 transplants to date, which seems to be a small number, but it's the largest center in the world, and we have delivered 31 children, which is phenomenal because it's beautiful. I keep saying phenomenal, but really it's, I don't know sometimes how to describe the fact there are 31 kids out there that could have been born in a different way through surrogacy, adoption, and that is beautiful in its own. But they were born with uterus transplant, and that's because we did it. And so it makes me very happy. As far as thus far, on one side, it's good for us because we are the only really active, continuously performing uterus transplant program in the country, at this point, probably in the world. But I'm sad on the other side that other institutions have not come to the table, and we have an open door policy. We have had colleagues from everywhere visiting us. So my hope is that more and more centers and just to let me say something that I really care tremendously about. I hope that people will see uterus transplant as a vehicle, almost like a Trojan horse, to reinvent, reinforce the conversation about fertility in this country, and the fact that I don't think it's for a society as advanced and beautiful as our American societies, give no attention from an insurance or to financial support to these women and to fertility in general. Doesn't show like a good sign for us. So I hope that since this has a lot of traction from a media point of view, that should be also a vehicle for the most important issue, which is fertility at large.
Very, very well said. Thank you very much, sir, for the time. This has been excellent.
Right. Thank you for having me. This was fun.
Absolutely.
All right.
Get ready for the must-attend event of the year in transplant science and immunogenetics. The ASHI 52nd Annual Meeting in Montreal, Canada, October 26th through 30th, 2026. Join world-class scientists, technologists, and innovators for cutting-edge workshops, interactive sessions, and breakthrough discoveries that are shaping the future of HLA and histocompatibility. Connect, learn, innovate. Whether you're a seasoned professional or emerging leader, this is the place to expand your expertise and spark new collaborations. Don't miss out! Be part of the conversation driving better outcomes for transplant patients everywhere. Register today and be inspired at the ASHI 52nd Annual Meeting.
All right, everyone, it's time for Tech Talk. Today, we're spotlighting Maria Ramirez, General Supervisor in the HLA Laboratory within the Department of Pathology at the University of Michigan in Ann Arbor. Maria recently earned a well-deserved promotion to HLA General Supervisor. Having immigrated from South America, she's built an inspiring career marked by resilience, dedication, and exceptional skill. Her leadership, deep technical expertise, and unwavering commitment to quality have made a lasting impact on her laboratory and colleagues. Maria consistently demonstrates excellence while mentoring others and helping advance the important work of histocompatibility testing. Maria, congratulations on your promotion, and thank you for continued contributions to the field. If you'd like to nominate a technologist for spotlight recognition, please email info@ashi-hla.org with their story and why they deserve to be featured.
If you need career advice or advice on how to deal with something happening in your lab, visit our podcast page at ashi-hla.org/page/ASHI podcast, or you can email us at info@ashi-hla.org and write the TEA in the subject line.
I have to say, when we first discussed having this episode, I was like a little hesitant about it, but ultimately this was awesome. I think I have so many follow-up questions about where we're going, what we can do, what this means for us as a society and a lab. I think, this is awesome.
Yeah, I mean, like, again, like fetal maternal medicine is already so complicated.
Yeah,
And now we're putting like an extra party in the system with great success. So many children.
I
I have
know.
to say, like, my father is a retired OBGYN. And I told him that we were going to be doing this episode, and he was so excited. And so he's gonna listen to the episode, and he's gonna have so many questions. But yeah, I mean, this is like a whole new forefront. I wish we had had time to ask, and now I feel like I'm going to go like to our transplant partners and ask, like, what is holding other centers back from doing this? That Baylor has an open door policy. Dr. Testa has an open door policy with talking about this. I wonder what the reservation is. I wonder if it's like there's not a registry, but there's so much enthusiasm to donate.
Yeah, I think I'm gonna go back. I can't wait for this episode to see the video. I want to go back and watch all of our faces light up when he said 31 babies have been born. Because I know all of us were just kind of beaming when he said that. It's exciting too, just how much work there is, how much of an opportunity there is. I know I got excited when we started talking about non-classical HLA. Like how fun is that? So a lot of cool opportunity ahead.
I know. And like, to me, it's one of the exciting areas that, continues to teach across organs, so to speak, right? Like we can take things we've learned from the sort of standard solid organ processes, right? And they're doing cross matching, they're doing antibody detection, right? And so, many of the things we've already become experts in translate very smoothly to sort of the next evolution, right? And the fact that there's such a drive of, women caring for other women to, willing to give them these experiences is, you know, it's a side that we don't talk a lot about, right? And being able to offer these sorts of experiences to other humans, and it's just a heartwarming story to hear.
Yeah, yeah. Well, listeners, I'm sure this won't be the last heartwarming story, but today was a lot of emotions. Woman power. Woman power.
Exactly.
Oh.
Until next time, guys. Bye.